Hi, I'm Lara Strawbridge, and I'm a Division Director at the CMS Innovation Center. Thank you to the National Cancer Policy Forum for including me today. I want to touch on 3 different topics today that demonstrate CMS's commitment to better healthcare data exchange. And we're looking to facilitate this in different ways through support, incentives, and requirements. So why do we want to do this? To be very clear, better healthcare data exchange will benefit patients. Specifically, it will inform decision-making for patients and their providers. It will support and improve patient care and outcomes. And ideally, it will reduce the administrative burden on providers and payers too. So as shown in the quote here on the slide, the CMS administrator has outlined our commitment to making healthcare data flow more freely and securely among payers, providers, and patients. So CMS published a final rule related to interoperability nearly 2 years ago, which requires certified electronic health records, or EHRs, to share their data via secure APIs to patients, providers, and payers starting January 1st, 2022. So this here is an example of our requirements to promote interoperability, or the ability to exchange data between devices and systems. So for example, patients can now exchange data with their healthcare provider using a personal health app. Of note, CMS did hear concerns from the payer community about operational challenges and risks to data quality in the absence of specific data exchange requirements and standards. So currently, CMS is exercising enforcement discretion with regard to the payer-to-payer data exchange until we undergo further rulemaking. We are also engaged with other activities, such as aligning with ONC on its U.S. Core Data for Interoperability initiative, which will create standardized vocabulary for core data elements. And we're also exploring the use of technology tools to streamline processes like prior authorization, as well as the use of a standards-based API for our price transparency efforts. Let's talk next about the Quality Payment Program, or QPP. QPP guides clinician payment for Medicare services. Previously, these were determined by the Sustainable Growth Rate Law until the passage of MACRA in 2015, which aimed to shift these clinician payments to be based on value and quality and not just utilization. So I wanted to flag before going into the slide that there are some exceptions for the Quality Payment Program, for example, if you're a small practice. But focusing on most clinicians who are affected by this program, MIPS has 4 categories, including promoting interoperability, and your score on these categories determines what kind of payment adjustment you get. Under the promoting interoperability category, there's a requirement that you use Certified Electronic Health Record Technology, or CERT. And for 2019 and then subsequent years, CERT is electronic health record technology that's certified by ONC and that meets the 2015 edition. It needs to include patient demographic and clinical information, such as medical history and problem lists. It needs to have the capacity to provide support for clinical decisions, to support physician order entry, to capture and query information related to healthcare quality, and to exchange electronic health information with and to integrate such information as from other sources, so moving back and forth between sources. I do want to note, if you participate in a MIPS alternative payment model, or MIPS APM, like some of the CMMI models I'll describe in a minute, your weights will be more favorable in the scoring. And there are also advanced alternative payment models, or AAPMs, which again include some of the CMMI models where CERT is required. And other requirements for AAPMs include things like outcomes-based measures and downside risk. Of note, if you meet the threshold established under an AAPM, or advanced alternative payment model, you're exempt from MIPS reporting and the scoring that's shown on this slide, and instead you get a 5% bonus for performance in 2022. But importantly, if you don't have CERT, you can't get the AAPM bonus. And if you don't have CERT under MIPS, you still get a score. It's just that your maximum score is more in the range of 70 to 75%. Thus, to be eligible for the highest and best adjustments, or to be eligible for the AAPM 5% bonus, you must use CERT. So lastly, let's talk for a few minutes about CMMI models in oncology. As many of you are aware, CMMI was formed by the Affordable Care Act to test innovative ways to improve care delivery and reduce spending. OCM is our flagship model. I should say the oncology care model, or OCM, is our flagship model. It's been going on now for about 5.5 years and has had significant voluntary participation. We have a number of different practice redesign activities, as we call them, that all participants must do. And one of those is that all participants must use CERT. Other activities include things like patient navigation, care planning, and 24/7 access to care. And of note, we believe that using CERT really is foundational to be able to do the other activities of the model successfully. We also have the radiation oncology model, or the RO model, which aims to improve quality and move to prospective site-neutral payments that are predictable. Of note, in comparison to OCM, which is voluntary, the RO model would require approximately 30% of the country to participate. Of note, this model right now is currently delayed by Congress to begin no sooner than January 1st, 2023. If the model moves forward, among other participation requirements is again the requirement to use CERT for all participants in RO that are in track 1, which is the advanced alternative payment model track. And like OCM, we believe again here that it really is foundational to be able to successfully do the other aspects of the RO model, such as clinical data reporting and treatment summaries to the beneficiary's referred provider after treatment ends. All those things really need to have CERT as an underpinning to being able to do them successfully. So now as we look ahead to future models in oncology, many of you are aware that we published an informal request for information, or RFI, in late 2019. The model that we described there would again require use of CERT. It also described that we were considering adding a requirement to this future model for a gradual implementation of electronic patient-reported outcomes, or ePROs. Information from ePRO systems can be used to monitor patient symptoms in clinical care and identify high-risk patients that are at risk for complications or utilization of acute care. Several recent publications have highlighted the value of ePROs in helping clinicians to stay aware of patients' clinical status and even to translate into improved survival outcomes. So we're continuing to reflect on the opportunity that ePROs may offer and appreciate all the helpful feedback that we've received from stakeholders since we put out the informal RFI. As we're planning for a future oncology model, we're really thinking about how we can best further the goal of better data exchange for patients' benefit. And in line with this, I want to mention that over the past year, many of you may know that CMMI has been engaged in a strategic refresh. There are 2 pillars in particular here that I want to flag that are of note to this conversation. One, in the middle at the bottom, is support innovation, which is really about leveraging a range of supports to enable integrated person-centered care, such as actionable practice-specific data and, again, technology. And then on the bottom right, there is partner to achieve system transformation. And here we're looking to align priorities and policies across CMS and also engage with payers, purchasers, providers, states, and beneficiaries to improve quality, achieve equitable outcomes, and reduce healthcare costs. In other words, we can't do it alone. All these pillars together will help us move toward a health system that achieves equitable outcomes through high-quality, affordable, person-centered care. So here on this last slide are just the standard disclaimers I'm required to give, and I'm looking forward to the panel discussion. Thank you all so much.